All right. So
Yes.
gives me great pleasure to introduce our speaker today. I have been his mentor only for 1 year, and he's only been with us for 2 years. So a lot of you may not actually know him. We wish we had him for 4 years, though. Dr. Aladdin Soufan is a graduate of the University of Michigan at Dearborn, where he did his Bachelor's of Science in Biology with high distinction. Went on to the University of Toledo College of Medicine and Life Sciences. From there, we actually interviewed him, but he went to University of Massachusetts Chan Medical School at Bay State Internal Medicine Peds residency program, where he did his first 2 years of residency. And then we were very fortunate to have a very coincidental thing where one of our residents needed to transfer there, and we were able to swap out for him and transfer him back to us. So he's done the last 2 years with us. Dr. Aladdin has a National Health Service Corps scholarship, and that's kind of in line with everything that he stands for. He's always been dedicated to serving the underserved populations, and this scholarship is kind of directed toward that. He has recently been the co-founder and director of the, I'm going to pronounce this wrong, Ghadir Bint Al Yemen Foundation, which has been a foundation to raise money for civilians kind of caught up in the tragic situations in Gaza and Yemen. He also is very active in the Islamic community, leads weekly sermons at Bronson Chapel, and actually did that at Bay State as well. And even before all of that, he founded a student-run clinic in Toledo. Some quotes from his supervisors back when he was in medical school said that even on his first rotation as a brand new medical student, he was functioning at the level, not only at the level of an intern, but at the level of an intern at the end of their first year. So that was pretty impressive. Another person commented that he rapidly makes connections with people of all different backgrounds and makes them feel comfortable. That's exactly what my feeling was when I first started working with him. Other faculty have commented that his organization and leadership skills are excellent. He makes connections with all patients, consistent with what his student supervisors said. He's smart, kind, calm, and effective. And the words kind and calm come up in like every evaluation he has. He has great bedside manner, great bedside communications, and amazing rapport with the patients. He's an excellent diagnostician and managed complex patients calmly. Again, that's a word that comes up, that he's calm even in intense situations. So I'm going to end with comments from his peers. Again, some of his peers said he's calm and composed, very supportive, one of the most organized seniors, perhaps the most kind and helpful senior I have ever worked with, always willing to help others. Aladdin has been here a short time. I can't even read my own writing. But fit in fast. He's hardworking, reliable, calm, even when things are challenging and chaotic. I wish he had been here with us longer, and me too. And then for a last one, I can always breathe easier going into his shift, knowing Aladdin is working. He is incredibly calm and has a positive attitude, tackles problems without issues. He is absolutely the best. So with that, Dr. Aladdin will be talking about breaking the cycle, addressing pediatric obesity through nutrition, policy, and prevention. So.
Thank you, Dr. Melgar. All right. So Again, I'm Alauddin Sufyan, and I'm a fourth-year MedPeds resident, and I'll be talking about pediatric obesity. So, pediatric obesity is a topic that I've been very interested in for a while now, because I've witnessed the effects of obesity on all of my patients who I've seen in the clinic, in the inpatient setting, and I've seen the downstream effects of it working in the internal medicine clinic more so than in the pediatric clinic. And as the saying goes, an ounce of prevention is worth a pound of cure. So it's better to address obesity in the pediatric population rather than trying to fix the downstream effects of it in adult patients and elderly patients. So here are some of the objectives we have. First objective is to describe the epidemiology, rising trends, and major health consequences associated with pediatric obesity. Number two is to identify key systemic, socioeconomic, and environmental factors contributing to the rising rates of pediatric obesity. To analyze the role of ultra-processed foods and poor nutrition in the development of pediatric obesity, as well as to assess the link between poverty and the prevalence of childhood obesity. And lastly, to implement practical clinical tools and community resources to support healthier nutrition among pediatric patients. So first, just a few disclaimers. Obesity is sometimes viewed as just a matter of personal choice, but obviously that's an oversimplification. It's not just about willpower or lifestyle decisions. But also to note, it's not solely due to genetics either. Only about 5% of severe pediatric obesity is due to a monogenic cause. And that means a single gene mutation, which is usually in the leptin-melanocortin pathway, which is involved with hunger and satiety. That's only 5% of severe pediatric obesity. So while genetics do play a role, obesity is not just simply a result of bad genes. There are many factors at play. It's much more complex. There are systemic factors deeply embedded in society that influence the development of obesity. So we know there are genetic and physiologic factors, but there are also socioeconomic factors like income, access to healthy food, and nutrition education, which all shape patients' eating habits and whether or not they develop obesity. Also environmental factors like access to parks, places for recreation, safe places to exercise, or even living in a food desert, which can make it harder for patients to maintain a healthy weight. Here are some just basic definitions, which we've all come across. BMI is just a measure of a patient's weight relative to height. It's calculated by your weight in kilograms divided by your height in meters squared. And this is a definition that it's not perfect, but it's a widely used tool in the literature, so we're using it. Overweight in a pediatric patient is considered a BMI between the 85th percentile and 95th percentile. Obesity is defined as a BMI greater than the 95th percentile. Severe obesity is a BMI at or above 120% of the 95th percentile. And then a food desert is a location where basically people don't have access to affordable, healthy foods. Either grocery stores are not nearby within a convenient distance for them to travel, or the grocery stores just they have a limited access for healthier foods. And lastly, food insecurity is just when people don't have consistent access to nutritious food, and they don't have enough of it on a regular basis. So just to introduce things, I want to talk about the scope of the problem. So let's talk about how things have changed since 5 decades ago. So back in the early 1970s, only about 1 in 20 kids were classified as obese. Fast forward to more recently, and that number has jumped to almost 1 in 5. That's a huge increase. And it's something that we have to understand and address and try to figure out why that's the case. So we all know that obesity impacts pretty much like the whole body. Majority of body systems are impacted by obesity. The most common issues we do see include hypertension, diabetes, OSA. Patients have joint problems and joint pain. They can suffer from mental health issues like depression, anxiety, and it can even affect growth and puberty in kids. And it even raises the risks for certain cancers. So I won't go into the details of how these things go about and arise, just because it would take a very long time, but we all know that obesity has a huge impact on the general health of our patients. So what are some things that have changed? One big systemic factor that is driving the increase in pediatric obesity is this increased consumption of ultra-processed foods. One study by Martinez and colleagues showed that about 2/3 of kids' calories today are coming from these ultra-processed foods. And that's a huge amount, 2/3. And that's things like ready-made foods like frozen pizzas, sugary cereals, like soda and juice. These foods are everywhere, and this is what the majority of kids love to eat, unfortunately. And they're very cheap, and they're easily accessible, so that's why they're so often, they're go-to for kids to be eating. So what does this term mean, ultra-processed foods? The term ultra-processed food was coined by a Brazilian professor and epidemiologist by the name of Dr. Carlos Monteiro. What these are is they're factory-made products, industrially made products, made from food ingredients like sugars, oils, starches, and artificial substances and flavor enhancers. And they often come ready to eat, and they contain a whole bunch of different additives that you would never find in a typical kitchen. And they're designed to taste delicious, and they're designed to be easy to overeat. And this can lead to patients consuming more calories than whole foods, which would fill you up much more quickly. So why are they bad? What's the issue with ultra-processed foods? I'd like to quickly go over a recent meta-analysis, which was actually just published last month in the American Journal of Preventive Medicine. Even though this research was done on adult patients or an adult population, the results of it are relevant, and it puts into perspective how bad of an influence ultra-processed foods are for our patients. There were two main goals for this study. The first goal was to estimate how much ultra-processed food consumption increases the risk of death from any cause or all-cause mortality. And the second goal was to quantify how much of a country's premature death burden could be linked to ultra-processed food intake. And the results showed a clear linear dose relationship, meaning the more ultra-processed foods people ate, the higher the risk of death from any cause or all-cause mortality. Specifically, what they found is that for every 10% increase in calories from ultra-processed foods, there was a 3% increase in all-cause mortality with a statistically significant confidence interval between 2% and 4%. The researchers, they also found that depending on the country, between 4 and 14% of premature deaths between the ages of 30 and 69 were attributable to ultra-processed food intake. And the highest percent of premature deaths attributable to ultra-processed foods was seen in the United States and the UK, where they had the highest population or the percent of ultra-processed food intake. So that's a big deal. This study showing that there's a link between consumption of ultra-processed food and all-cause mortality and premature death. So now that we recognize how much of a negative impact these ultra-processed foods have on our health, how do we minimize this effect? One way is being able to identify which foods are truly ultra-processed. So this Brazilian epidemiologist and professor, Dr. Carlos Monteiro, he developed the NOVA system, which categorizes food based on basically how processed the food is. So group 1 is natural, real food, natural stuff that like fruits, vegetables, meats, what most people would recognize as food. Group 2 is basic kitchen ingredients like olive oil, spices, stuff that you make food with at home if you're making your own food. Group 3 includes processed foods. These are basically those two groups, group 1 and 2, mixed together to make basic foods like bread or jam. So foods made from a few real ingredients. And then group 4 is ultra-processed foods. Ultra-processed foods is, like I said, they're industrially made, like factory-made food with ingredients that you would definitely not find in your kitchen. A lot of them we can't even pronounce. A lot of times there's additives, there's flavor enhancers, artificial colors. You think of like fast food, think of like frozen packaged foods, sodas, things like that, or microwave meals, ready-made meals. These ultra-processed foods, which a lot of us, we eat because they taste good and they're convenient and they last a long time, they're a very big reason why obesity rates have been rising in kids especially. So I can't talk about pediatric obesity without talking about sugar-sweetened beverages. So sugar-sweetened beverages are just like what they sound. They're just any liquid that is sweetened with any type of sugar, whether it's like glucose, sucrose, fructose, or any type of sugar really. And some examples are soda, energy drinks, fruit drinks, sports drinks, these types of beverages. And all of these contribute to the added extra sugar in kids' diets. And there's well-established literature that links increased sugar-sweetened beverage intake to obesity. And this happens across the board, not just for pediatric patients, but also for adults. And this is actually a point that I learned from Dr. Melgar in clinic when advising patients about how to improve their diet. He said to sort of focus on one thing that they can practically take, one action that they can practically take. And this is one of the best actions you can advise your clinic patients to avoid, is to basically only drink water, because these sugar-sweetened beverages, they add a whole lot of calories into a small amount, a small volume, and they don't fill you up, so you're able to overeat very easily. It's easy to drink a whole bunch of calories without even realizing it. And then another thing is many of these sugar-sweetened beverages contain fructose, which is primarily metabolized in the liver, and it can lead to hepatic steatosis or fatty liver, as well as insulin resistance, which is a big factor in developing obesity and diabetes down the line. Now let's talk about what makes these foods so delicious. So many corporations actually hire food scientists to design food products which are almost irresistible. These foods are called hyperpalatable foods. Hyperpalatable foods are basically foods with the perfect combination of fats, sugars, salt, and different additives in it that makes the foods very hard to resist. They make the foods very delicious and very, very easy to overeat too. These foods will light up our brain's reward systems and shut down our brain's satiety, basically the signals in our brain which tell us that we're full. So when kids eat these foods over time, it can actually change what they want to eat later on. When they start eating a lot of hyperpalatable foods, they'll reach to those foods more so than they would reach to fruits or vegetables or healthier alternatives. So starting young with a lot of hyperpalatable foods sets these kids up, unfortunately, for higher risks of overeating and obesity down the line. And one interesting fact is the early Coca-Cola formula actually contained cocaine from coca leaves before the recipe was changed. So even more addictive. Although ultra-processed foods can be addicted to certain people and in certain populations, the Coca-Cola actually contained cocaine from coca leaves, which I thought was crazy. So it's not just the ingredients that make these foods irresistible. Marketing also plays a huge role. Companies invest millions of dollars in advertising strategies, and they design it specifically to target children, oftentimes. They use bright colors, catchy tunes, cartoon characters, and even celebrity endorsements. I was on nights on the inpatient peds, and on the TV, there was an advertisement playing. It was one of the wrestlers. It was John Cena, and he was advertising a sundae, ice cream. So to me, I'm thinking this person who is supposed to be somebody who is an athlete of some sort, he's advertising something that directly negatively impacts kids' health. So And studies have shown that low-income and minority kids are often exposed to even more aggressive marketing. This constant bombardment of advertising of ultra-processed foods, this shapes these kids' food preferences down the line, and it increases their likelihood of choosing these unhealthy foods and overeating these unhealthy foods. Unfortunately, it's a deliberate strategy from the companies, because obviously companies want to maximize their profits without regard to whether or not this is a healthy thing for the kids that they're targeting. So why are these foods so popular? It's pretty simple. They're convenient and they're cost effective. They're easily accessible and they're cheap. Nowadays, it's kind of rare to find a family where they're making most of their meals at home. Rather, people are buying a lot of their meals from, like, ready-made meals from outside of the home or fast food. A lot of these products that are unhealthy and highly processed, a lot of them are very inexpensive and widely available, especially in low-income neighborhoods. And for a lot of families, these foods are just the most practical option, even if they're not the best for long-term health, unfortunately. I'd like to shift a little bit and talk about another piece of the puzzle, which is U.S. farm policies. So U.S. farm policies, they mainly subsidize crops like corn, wheat, soy, and sugar. And this means ingredients like high fructose corn syrup, refined flours, vegetable oils. These tend to be very cheap. And these are the main ingredients you'll find in ultra-processed foods. Unfortunately, fresh fruits and vegetables and whole grains, they don't receive the same or similar support, which makes them more expensive. Another factor is that there's higher costs associated with growing and transporting fresh produce. So this leads to a situation where processed foods are very cheap, widely available, and the healthier options are more expensive and less accessible. This is a picture just to illustrate this concept here. On the left, you'll see the My Plate, which is a visual representation of how much of each food group the USDA recommends to help people make healthy food choices. The plate on the right side of the screen is how much each of these food groups actually get subsidized by the government. So as you can see, that tiny little sliver in green is fruits and vegetables. These are not subsidized as much, so they end up costing more. And the subsidized crops are what are used to as ingredients for these highly processed, ultra-processed foods. So the calories, the increased calories, increased sugar, fat, all that is basically indirectly being subsidized by the government, whereas the healthier alternatives are not. I'd like to also touch upon briefly about the socioeconomic angle. So low-income families often have barriers to accessing healthy foods, like living in food deserts, in which fresh produce is not easily accessible. It's kind of, if you think about it, it's rare for there to be like a Whole Foods or a Trader Joe's within a very low-income neighborhood. You'll find those places in higher income neighborhoods. So this is one of the things that contributes to food insecurity, the fact that these patients and these families are living in areas where it's not easy for them to access healthy foods. So as I mentioned before, it's not only about personal choice, it's also about access to nutritious food. Young kids and adolescents, they don't choose what type of food their family can afford, or they don't choose where they can live, or where they're able to live. So what we're looking at here, unfortunately, it's like a vicious cycle. Economic stressors drive families toward ultra-processed food, which then contributes to childhood obesity. As these kids grow up, the cycle continues. Their food preferences change. Those are the foods that they go to, that they're used to eating. Bad eating habits become ingrained, and this leads to long-term health problems. And breaking this cycle is crucial if we're going to reverse the trend of childhood obesity and obesity in the general population, really. So as pediatricians, we're in a unique spot to help break this cycle. What we can do is we can educate families about what healthy eating really looks like. We can help them identify nutritious options, and we can suggest practical changes that fit their lifestyle. A lot of these parents, they may want to do the right thing with their kids and feed them the right foods, but they may not know where to start, or they may not have the means to make healthy food choices for their family. So we as pediatricians, by guiding them and pointing them towards resources to help, we can make a huge impact on our patients' long-term health. One practical tool we can use in the clinic is the Hunger Vital Signs. This is a simple 2-question screening tool, which helps us identify families who experience food insecurity during routine visits. And once we flag a family for who's at risk, we can connect them with local resources and programs to make sure that each child gets the nutrition that they need. So this is what the Hunger Vital Signs screen looks like. It's just 2 questions. The first one is, within the past 12 months, we worried whether our food would run out before we got money to buy more, and there's options, often true, sometimes true, never true, and then don't know. The second one is, within the past 12 months, the food we bought just didn't last and we didn't have money to get more. So the screen is positive if patients select sometimes true or often true to either of those questions. So once we are able to identify patients or families at risk, we should be able to then try to figure out how we can give them the resources that would help them get the nutritious food that they need. So it's not just up to us as pediatricians, but we have to work together with policymakers to push for changes that would improve the health of our patients. Policies that increase access to fresh fruits and fresh vegetables in low-income areas, combined with nutrition education, this can make it easier for families to make healthy choices. And this is a collective responsibility. It's not just on one profession or one group of people. It involves schools, local governments, and community organizations. So there are examples of how this has worked in the past. There's one successful program. It's called Gus SNP, or Gus Schumacher Nutrition Incentive Program. This is a program by the USDA that makes it easy for low-income families to get access to healthier food. And what this program did was it offered grants to organizations which subsidized the cost of healthy food for these families. In just 1 year, the program provided over $52 million worth of fruits, fresh fruits and vegetables. And then one cool thing that they did was they let physicians actually write prescriptions for fruits and vegetables. And basically the families were allowed to get certain vouchers or scripts to pick up fresh fruits and vegetables. And this program subsidized that, so it was paid for by the government. This program reached over 230,000 people all across the country. Plus, it was not only good for the patient's health, but also it was good for business too, and good for farmers, because it added more than $107 million into local businesses and to farmers. And it worked because people reported eating healthier and they felt like they were more food secure. And it shows, and this program shows, that if you are putting money into the right places and the right programs, you can actually make a positive change to public health. Another thing, another change is that there's 2 things here. Number 1 is changes to SNAP. So SNAP, for those of you who don't know, it's what's commonly known as food stamps. It's basically a program the government uses to help people who are unable to purchase food. They basically get kind of like a debit card, and they're able to use it to buy food. One change that would help in combating pediatric obesity is making some changes to SNAP, and a couple of things. There's one called Double Up Food Bucks, which is something that in Michigan, it's a dollar for dollar match that people will spend up to $20 a day, and the government will double that amount that they're covered. So instead of spending $20 on fruits, they're able to spend $40 on fruits and vegetables. And there's many different farmers markets and grocery stores that accept this. So that's one change to SNAP that's been positive. Another change, it's not an official change, but it's a proposed change. It's restricting unhealthy food purchases. There's a lot of talk, proposed bills about cutting back on SNAP covering unhealthy foods, covering like soda, covering candy, these types of things. It's not just about taking away help, it's kind of like trying to guide families towards making the right food choices. This is the Double Up Food Bucks. This is the website. And I just put in the clinic's address, 1000 Oakland Drive, and there's 3 up here that accept that program, as you can see on the screen. So if you think that your patients, whether they're pediatric or adult patients, if you think that they would benefit from this program, you can direct them towards this website. Double Up Food Bucks is what it's called. And each state has a similar program. They may call it something different, but each state has a similar program that if you're practicing somewhere else, that you can direct your patients to. It basically doubles their amount of SNAP benefits if they're using it to purchase healthy foods, specifically fruits and vegetables. Here is a screenshot of the congress.gov website. This lists the Healthy SNAP Act. And this is basically that proposed bill, which I was talking about, that is trying to restrict unhealthy food purchases. As you can see where it's highlighted in the bottom there, it says under the bill, SNAP benefits may not be used for soft drinks, candy, ice cream, or prepared desserts like cakes, pies, cookies, or similar products. And then down below it says USDA must also, to the maximum extent practicable, ensure that fat, sugar, and salt content of the food and food products are appropriate. I'm not exactly sure what they mean by appropriate and who's going to determine that, but I think generally it's a good step for the government not to be subsidizing people buying soda and candy and things that are making people unhealthy. So while the Healthy SNAP Act is a proposed bill, this bill here is one that was actually passed in the Arizona House of Representatives just last month, actually. It's called the Arizona Healthy Schools Act, and here's the text of the bill. So basically what this bill says is a public school may not serve or sell ultra-processed food on the school campus during the normal school day. And how they defined ultra-processed food is a food or beverage that contains one or more of the following ingredients. And they listed 11 ingredients, which are often added in ultra-processed foods, certain dyes mainly. And I'll just, because I think it's relevant, I'll just read this bottom portion. It says the legislature finds that childhood obesity, morbidity, and wellness are matters of statewide concern. Ultra-processed, industrially manufactured, nutrient-depleted food with synthetic additives is undernourishing minors at public schools and contributing to childhood obesity. Any taxpayer-funded meal or snack program offered to minors at public schools in this state should be nutritious and made primarily of whole, minimally processed plant or animal products. I don't think anybody would refute that. I think this makes perfect sense, that if we are paying taxes, we shouldn't be paying taxes to fund unhealthy foods for our kids. And just by looking at that first ingredient, potassium bromate, this ingredient was banned by the European Union in the 1990s because of concerns that it's a carcinogen. So these ingredients, they're not harmless. You know, there is some harm to them, and we may not see it directly, but down the line we could see it. Another way that families can get help to eat healthier is through community-supported agriculture, or CSA. So this is a model that connects local farmers with community members. Families subscribe to CSA programs, and they receive a share of fresh seasonal produce directly from the local farms. So this not only improves access to nutritious food, but also encourages community engagement and nutrition education as well. And there's research that shows that families that participate in CSA had increased fruits and veggie consumption. It's like a certain amount that they pay per season, and they get like a certain amount of fruits and vegetables back from these farms. And then I touched upon this a little bit before, but food pharmacies. So food pharmacies are programs that allow doctors to prescribe healthy food. They offer vouchers for families to get fresh produce and other nutritious options. This is actually something that during my job search, I saw at some clinics where the clinics had basically a food pharmacy where the physicians would prescribe, would give the patients a voucher, and then they would be able to go dispense certain fruits and vegetables. If you think about it, like if we are able to prescribe medications that cost hundreds or even thousands of dollars per month to fix a problem likely caused by bad diets, then why not try to fix the problem earlier with a fraction of the cost by being able to prescribe healthier foods and get our patients access to healthier foods, which could help prevent the disease before it occurs. And then we're not spending hundreds or thousands of dollars on medications every month that could have been prevented. So some countries actually have started taxing sugary drinks. In Chile and Mexico, these taxes have led to a drop in the consumption of unhealthy sugary beverages, and they've improved the public health outcomes. So in Mexico, it's a 1 peso per liter tax, and the study found that this is projected to prevent almost 240,000 cases of obesity, 39% of which would be in children. Another example is the sugary beverage tax actually in Philadelphia. So back in June of 2016, Philadelphia became the largest US city to pass a soda tax, and it went into effect January of 2017. It's just 1.5 cents per ounce of soda, so it's about an extra $1 per 2 liter. And this led to a 51% decrease in the volume of taxed beverages sold in Philadelphia. Another place that did this was Seattle, Washington. They started taxing 1.75 cents per ounce in 2018. And one cohort study found that the Seattle sweetened beverage tax was associated with a modest decrease in BMI among children living in Seattle when compared to children living in nearby non-taxed areas. So last couple of slides I have, I want to just talk about briefly regarding screen time and sedentary lifestyles and the impact on childhood obesity. So going back to the 1970s, screen time in the 1970s was mostly limited to TV. Kids started to watch TV around the age of 4 years old, and they averaged about 2 hours of screen time per day. Fast forward to more recently, to today, things have changed dramatically. Children between the ages of 8 to 12 years old now spend between 4 and 6 hours daily in front of different screens, and including TVs, computers, smartphones, tablets, while teenagers can spend up to 9 hours a day in front of a screen. It's a full-time job. This increase in screen time has led to a decrease in physical activity, and studies have shown that there's a strong association between high screen time and decreased physical activity. And this has contributed to higher rates of obesity in children and adolescents. So as I mentioned at the beginning of the presentation, pediatric obesity increased from about 5% in the 1970s to almost 20% now. This increase in obesity has definitely been worsened by increased sedentary lifestyle in kids and increased screen time and decreased physical activity. So to address this issue, we have to educate parents and patients about how much prolonged screen time contributes to obesity. The AAP recommends children between ages 6 and 17 years old should get 60 minutes of physical activity every day. And for kids between ages of 3 and 5, they should be getting at least 180 minutes of physical activity per day. So this study here, it's a 2023 study. It looked at almost 6,000 kids in the US between the ages of 10 and 14. On average, these kids were getting about 6.5 hours of screen time per day. And they averaged about 9,200 steps per day. What the study found is that kids who had high screen time, over 8 hours per day, they were 29% more likely to be overweight or obese, even when you accounted for how much physical activity they got. And the reverse was true. Kids who were very inactive, who had less than 6,000 steps per day, had a 30% higher risk of obesity, even if they weren't on screens all day. So what does this tell us? It tells us that kids really need both low screen time and high physical activity to get the best outcomes and have the lowest risk of developing obesity. So just hitting the steps goal, it doesn't undo 8 hours of scrolling through TikTok or watching videos online. And the same with the other way around. If you just cut down on screens, it's not enough if kids are not active, physically active. So this gives strong evidence that we need to advise our patients and the parents of our patients to ensure that kids are both cutting back on screen time as well as increasing their physical activity. So to wrap it all up, childhood obesity isn't just about one or two simple factors. It's a complex issue. It's driven by not just personal choice or genetics alone, but also by multiple societal factors, including socioeconomic and environmental factors, which drive many families to rely on cheap, ultra-processed foods. The good news is that we have solutions on multiple levels to combat this. Personally, as physicians, as pediatricians, we can educate families and we can use screening tools like hunger vital signs. On a policy level, we can advocate for initiatives like GUS-SNP, SNAP changes, food pharmacies, community-supported agriculture, restricting harmful food additives in our kids' foods. All of these are steps in the right direction. So what are the key takeaways? If we focus on early specific actions like screening for food insecurity, counseling families about nutrition, and supporting and advocating for policies that increase access to healthy foods, we can start to slow and even reverse the rise in pediatric obesity. It's not about fixing everything at once. It's about taking clear steps that lead to lasting positive change. And I hope that each one of us will be a part of that change.